So we're just going to get started so I can jump in. And again, thank you again, Allison, so much for joining our Pepper Center grand rounds. And this is something we started more recently as in 2022 as a means to kind of get to allow us to meet other aspiring junior faculty doing great things that we would want to know about, and for you to also maybe get to know some of our investigators as well. And hopefully we'll have collaborations, and I know that we've already started. So for those of you, I wanted to just introduce briefly Dr. Allison. She at the University of Iowa College of Nursing. I've gotten to know her as in the very first National Pepper Center research meeting that I attended. We all attended. For those of us on the Pepper Center side, I met Allison while she was presenting at a mock study section, one of her applications, and it rang true to me so much of what her work is, aligns perfectly with our Pepper Center. And Allison was attending the meeting as a MCC scholar, a multiple chronic conditions scholar with the Aging Initiative, which is kind of a complement to the Pepper Center network nationally, funded by Jerry Gerwitz at University of Massachusetts, and also co-led with by the Pepper Center at Maryland, Jay Magaziner, that really has almost like an identical mission. And the Aging Initiative actually wrote a letter of support for our Pepper Center, given that our themes are so closely aligned. But as you can see by her presentation and that she's going to be sharing with us today, her research really does have so much similar trends that we kind of are engaging in within our general internal medicine and also in CARA. So I'll leave it to you now, Allison, to take it off and introduce things. Again, thank you so much for joining us today.
Yeah, thank you so much for the introduction. So my name is Allison. I'm really happy to have this opportunity to share my research with you. I know you guys are all experts in dementia and also the multimorbidity. So I'm still developing my research. So I'm really welcome to your feedback and advice how to improve my research work, and also hope we can identify some opportunity to collaborate. So just a little bit background of myself. I completed my undergraduate study in Taiwan. I grew up in Taiwan, and then after that, I went to UC San Francisco and the University of Washington, Seattle to study my graduate study in clinical informatics and the nursing. And after I completed my graduate studies, I have been working as a assistant professors in University of Iowa since 2017. And so for my research, I focus on integrating technology and advanced data science to promote dementia care, multimorbidity, pain management, and also family caregiving. And today I will share two of my current projects. So the first one is I use advanced data analytics to analyze the EHR data to categorize patterns and groups of multimorbidities in patients with dementia. And this is a NIH administrative supplement grant to our P20 Centers for Advancing Multimorbidity in our College of Nursing here. And my second project I will talk about, currently I'm developing and also testing a web-based application that is to support family caregivers to manage pain for people with dementia. And this project is funded by Alzheimer Association and also the Somei Geriatric Center here in our College of Nursing. And as Michael mentioned, he served as a mentor for this project as well. So I really appreciate the collaboration. So I have no conflict of interest to report. And so the first project is multimorbidities in people with dementia. There are over 55 million people worldwide, and 16 million Americans living in dementia. And multimorbidity is a big issue in this population. So for example, 83% of older Medicare beneficiaries, they have dementia. And among them, more than 95% of them actually have more than one other coexisting chronic conditions besides their dementia condition. And almost 3 times more beneficiaries with dementia. They have 4 or even more multimorbidities than beneficiaries without dementia. And we all know about 2/3 of Medicare and Medicaid payments actually goes to treat patients with dementia, not including their other chronic conditions. However, this is a big issue, but we still have really limited knowledge in these topics. So studies review all the current clinical practice guideline for patients with dementia. They find only 30% of the clinical practice guideline actually address how to manage multimorbidities in patients with dementia. And also, based on my knowledges, I only found 4 studies were conducted to explore types of multimorbidities in people with dementia. And those existing studies, they found some common coexisting conditions like chronic kidney diseases, ischemic heart diseases, depression, hypertension, stroke. Those are the common conditions in this population. However, when I look at those studies, I found most of them only use descriptive statistics, so they can only provide us information on the frequencies of common and single chronic conditions. But we all know, like, people with dementia, they do not have only one chronic condition, they have multiple chronic conditions. So if we only use descriptive statistics, that cannot provide us information on the patterns of those chronic conditions or how correlation of those chronic conditions. And also I found those articles, published articles, they most of them use data from national claims data or national health survey. So they are able to only look at the data for a specific period of time. So some of them use the data for what patient data for 1 year or 5 years. So they do not kind of provide longitudinal information on patients' their chronic condition. So to address these questions, to address those gaps, my research is I want to use the EHR data. EHR data can provide us like more longitudinal information on patients' their chronic condition. And I also use advanced data analytics, so try to identify common and also highly correlated patterns of multimorbidities in patients with Alzheimer's disease. Why I focus on Alzheimer's disease, because this is the most common types of dementia, and I realized different subtypes of dementia, they may have a different chronic cause or chronic conditions. So in this project, I only focus on people with a diagnosis of Alzheimer's disease. And for my research aims, I have 2 major aims. So the first one, I want to identify not only the most frequent, but I also want to see highly correlated patterns of coexisting chronic conditions in patients with Alzheimer's disease. And we recently just finished the analysis. So in my presentations, I will share my results. And currently, my team and I, we are still working on analyzing and compare the healthcare cost and pain symptomology among those identified groups, multimorbidity groups. So this is my study design. I extract EHR data from the University of Iowa Hospital and Clinics here. And I include EHR data from adult patients if they have ICD-10 codes of Alzheimer's disease, Alzheimer's diagnosis. So that is including G30 and their children. And I include patients if they have at least 1 clinical encounters in our medical centers from 2008 to 2021. How I define chronic conditions after review the literatures, I choose Codalong inventory list. That's a list including 918 common chronic conditions, and I use the list to guide the identification of chronic conditions in my sample. And these slides just share the statistical analysis I use. I use both support and the leverage to help me identify the patterns of multimorbidity in our sample. Suppose it's really straightforward, just as you know, is the frequency and percentage of one chronic condition. And leverage is a correlation measure. This method is usually used in a big data set when you're looking, when you look at the correlation between two chronic conditions. And you can see the formula I highlight in yellow. This is the formula I use. So leverage can tell me the differences of the actual support of two chronic conditions, so I can know the big differences than their actual support. So if the higher leverage can kind of tell me the big differences than their actual support, and then how two chronic conditions they independent to each other. I know this may take some time to process, but I'm happy to talk about this if you want to have more explanation. And this is a result of my findings. This is our demographics. We were able to have the EHR data from 2,600 patients from the UHC. The mean age of our sample is 83.5 years old. Dementia, that is understandable. Dementia is an aging disease, and 60%, more than 60% of them are female. And we also find like our sample is not racially diverse. More than 94% of our people, their race is white. And then we also have a couple of people, they are from other races. So this is one of our limitation. And when we look at number of coexisting chronic conditions, the average number of coexisting condition is 13. So that is a huge number. And the largest number chronic condition is 5. So people with 5 coexisting chronic condition is the largest groups in our findings. And this slide is just show the top 20 common chronic conditions in our sample. And you can see for the top 20 conditions, we use a percentage to present. Hypertension is the number 1. We have more than 50% of our samples, our patients, they have hypertension. And disorder of lipoprotein metabolism is another big one. Depression, anemia, kidney diseases, they are also really common in our patients. When we do our analysis, we also find another limitation from the ICD-10 code, because some of the ICD-10 code are really abstract. So for example, we have huge number of patients, they have a diagnosis like general mental disorder, disorder of joint, disorder of urine system. Those diagnoses do not really provide too much information for us. And the next slide, I will show the groups and patterns of multiple chronic conditions we found. So first we start from the combinations of 2 conditions. And as I say, I use both support frequencies and the leverage I apply both of them, and those help me to identify not only common, but also highly correlated conditions in our sample. So here are the common and correlated patterns of 2 conditions. So I found hypertension is usually come with disorder of lipoprotein, or hypertension come with kidney disease, hypertension come with diabetes, or diabetes is come with disorder of lipoprotein metabolism. And this is the common and correlated patterns of 3 conditions. And I found disorder of lipoprotein metabolisms often come with hypertension, ischemic heart disease, the presence of cardiac or vascular impairments, and diabetes and kidney diseases. So I find most of them are cardiovascular disease, and then they usually come with come together with kidney diseases and diabetes. And when I look at the common and correlated patterns of full condition, the combination, and I still see the similar patterns. Hypertension, disorder of lipoprotein, cardiovascular disease, they come with kidney disease and diabetes a lot. And before I jump to the discussion session, I want to talk about some strengths and limitations of our study designs. For this analysis, I choose a comprehensive codon inventory list. This list is kind of including 918 really common chronic conditions. So that can kind of give me the ability to look at the patterns of comorbidities, because for previous study, a lot of study, they usually use some pre-identified small number chronic conditions when they look at these issues. So for example, some article, they usually use maybe most common 10 or 20 chronic conditions in dementia, and then they use that to guide their investigation. We use codon list kind of, they have a huge number of chronic conditions, so that gives us the ability to comprehensively look at this issue. And I also use both correlation measures and also statistic analysis, so to help us identify patterns of multimorbidities. And there are also some limitations about our studies. So for example, a lot of our findings are limited by the ICD-10 codes. Some of the ICD-10 codes are really general, do not really give us too much information about patient specific conditions. So a lot of diagnosis we get is like a sleep general mental disorder, joint disorder, urinary system disorders. So those are kind of just too abstract to prescribe to describe patient's condition. And we also found sometimes EHR documentation does not always match a patient's real conditions. So some conditions are least identified or diagnosed in dementia populations. And another limitation is about our sample, like we lack racial and ethnic diversity. So that may exclude some patterns of comorbidities found in a broader population. And so discussion, so for our studies, we identify cardiovascular disease, kidney disease, diabetes, depression, those are common conditions in our sample. And this is really consistent with the previous research and studies. And besides those findings, we also identify general mental disorder, anxiety, urine disorder, anemia, vascular dementia are also really common in our sample. And we also find, because we include patients with Alzheimer's disease, but we also found some of them also have a vascular dementia. So that means our patient, some of our patients, they have a mixed dementia. And from our findings, we found cardiovascular disease, kidney disease, and diabetes, they are highly common and correlated in our sample. I think this is understandable because cardiovascular disease and Alzheimer's disease, they share a lot of similar pathological mechanisms and also genetic risk factors like lipoprotein E. And because the long-term vascular dysfunction that impair patients their vascular clearance of the amyloid beta and tau protein in their brain. So there is an association between cardiovascular disease and Alzheimer's disease. And so we want to we agree with the previous studies, will control patients their cardiovascular disease, and their blood pressures can reduce the likelihood of developing Alzheimer's disease, and also reduce the Alzheimer progression. And kidney diseases and diabetes usually come with a cardiovascular disease in our sample, and it's kind of explainable because cardiovascular kidney diseases kidney function is found like associated with the cognitive function in previous studies, and previous study found patients their cognitive function improve, their cognitive function and memory improve after the kidney transplantation. So it is really important to regularly assess the risk of Alzheimer's disease and the kidney diseases in people with cardiovascular disease. And for the diabetes, we already know diabetes is a contributing factors to Alzheimer's disease, and also is one of the most preventable metabolic disease. So our studies agree that if we can manage blood pressures, weight, cholesterols, and blood sugars that can well control those risk factors that may reduce the risk of getting Alzheimer's disease or even reduce the progression of Alzheimer's disease. And that leads to our future direction of this research. Right now, we use these methods to show it is feasible to analyze the patterns of Alzheimer's disease, patterns of multimobilities in patients with Alzheimer's disease. And our next step is we want to use some national data sets to identify the patterns of multimobilities in a larger and diverse groups. And right now I'm still thinking the potential data sets we can use. So if you have some ideas or feedback, I'm welcome to the discussion. And right now, my team and I, we are still analyze the healthcare cost and also the health costs in those identified patterns. And we also want to look at their medication use, and then we hope that can help de-prescribe in this population. I actually have the medication used for my sample, but at this time, I just do not have I just do not start to analyze or have time to do that. So I'm also welcome to collaborate with experts in analyze the medication use for this sample. Yeah, and my team and I currently, we are also plan to develop prediction models so we can early predict the patterns of multimobility in people with dementia and hope to reduce the risk of getting some comorbidities. And ultimately, we hope this program of research can inform clinical practice and research on how to manage chronic conditions in patients with dementia. Do you have any question on this one in these projects?
I have one question about the leverage. Can you go back to and sort of go over again what are the numbers leverage telling us?
So it's so you can see that the leverage is the leverage is used to describe the correlation between two conditions.
Yep.
And then so the support is the percentage of two conditions they will occur together. So I use this percentage to minus the individual percentage. So that can see the actual the difference between the actual support for those two conditions. And then in this condition, in this case, those two conditions are independent to each other.
Okay.
So if I can find a bigger, if I can find a bigger leverage, that means kind of give you some surprising findings. Yeah. And then you want me to go to the tables I have?
Just sort of I'm trying to sort of clinically understand what is a leverage of 0.096 tell us that?
Right. Usually it's like the range of leverage is from 0 to 1. And then if the number bigger means like the bigger differences between the actual support. Yeah, and so when I look at that, I balance both of two kind of measures, percentage and leverage, and then I identify those groups. Yeah. And it's it's a kind of like a lot of like mechanisms behind that. Yeah.
Looks like Lisanne Jenkins has a question.
Yeah.
Hi.
Hi.
Can you hear me?
Yeah, yes, I can hear you.
Hi, thank you. That's a really interesting discussion. I was wondering whether you think in the larger, more diverse cohort that you will see any differences in the patterns of relationships or just a worsening, because we know, for example, in African Americans that they have a lot more risk factors. So you're thinking that the patterns will differ or
I
just
think the patterns will different. I think right now I only find 1 or 2 articles. They kind of look at the they look at the common conditions for different races, and then look like Asian, white, and African American. They all have a different common conditions. But as I say, like most of the study do not look at the pattern. They only kind of look at the most common single condition. Yeah. So I think that will be really interesting to compare the patterns among different racial groups. Yeah, and then right now we are just thinking, we are still like brainstorming which national data sets we should look at. Should we look at some Medicare data from Medicare, or some insurance claim? Or recently Epic, they have a big, they kind of open their data set. Is that called Cosmo or something? Like they have 200 million EHR data will be open. Something. This is another potential data set we are considering.
That'd be great.
Yeah. Any other question before I talk about the second project? And as I say, I also have the medication use for my current sample, but just I haven't been able to start to analyze that. Right now, I focus on analyze the healthcare costs among those identified groups. So if you have some ideas or you would like to collaborate on analyze medication in these groups, that I'm really welcome to have the opportunity to collaborate. Yeah. Yeah. Okay, so I will go to the next project. Is I am developing and also testing web-based applications that is for family caregivers to manage pain for patients with dementia. And why I focus on pain symptoms in people with dementia, because pain and dementia both are really serious and also really expensive healthcare concern. So right now, more than 100 million Americans, they have a chronic pain and also unrelieved pain, and that costs a lot in our healthcare. And recently, a study conducted by Duke Pain Clinic, they found they provide patients with adequate and personalized pain management regimen that can actually reduce 50% of healthcare cost. So if we can provide patients with effective pain management, I think that can save a lot of costs for the healthcare system. And just some background information, risk factors of pain in people with dementia. There are a lot of risk factors can cause pain in this population at advanced age, that change patients, their sensory fibers, or change in their pain receptors in their brains. So that can cause pain in this population. Cognitive impairments, depressions, social isolation, and also comorbidities, a lot of chronic conditions that can cause pain symptoms in patients with dementia. And those are just some common comorbidities can cause pain in dementia. So that including arthritis, fractures, and also diabetes neuropathy, and also some cardiovascular conditions. And those are some consequences have been reported. Consequences of unrelieved pain have been reported in literature. Pain symptoms that can affect patients, their daily activities of daily livings, and in patients with dementia that can cause depression, anxieties, and also some psychiatric symptoms, and also affect their cognitive function. And because those psychiatric symptoms, that may also increase patients their risk of getting inappropriate psychiatric medications. That increase healthcare costs and also caregiver burdens of taking care of patients. And there are some gaps in providing support for family caregivers to providing pain management for people with dementia. Currently, about 60 million of Americans, they are the family caregivers of people with dementia. And 60% of people with dementia, they live in community and really rely on their family caregivers. And more than 50% of the people with dementia, they actually have pain symptoms because the neuropathological changes in their brains and also other painful comorbidities we mentioned before. And during the clinical encounter, because the time is usually too short and caregivers, they do not receive adequate information in how to providing pain management from their care team. And there are also no intervention placed in clinicals that can support family caregivers. And when I reviewed the literatures, I also found we do not have intervention to support family caregivers, specifically for family caregivers or patients with dementia in providing pain management. And my team and I, we have been conducting some research, try to understand these issues. So we look at what are the common challenges for family caregivers when they providing pain management, and what are the existing interventions for this issue. So I have been conducting some secondary data analysis and also systemic reviews, try to look at specific challenges they have. So we have a secondary data analysis from interview from family caregivers, and also look at the nursing and caregivers, their communication in pain management during the home visits. I recently also complete a systemic review of 55 studies that kind of discuss and explore challenges that family caregivers they face in pain management. Two of our secondary data analysis have been published in American Journal of Hospice and Palliative Care Medicine, and also Journal of Pain and Symptom Management. Yeah, and this is my findings. There are a lot of challenges family caregivers they can face when they provide pain management. So that can be caregiver-centric issues. A lot of caregivers, they are older adult themselves. Function, cognition issues in family caregiver themselves interfere with their ability to provide pain management. And a lot of time, family caregivers, they have limited knowledge and skill on how to manage pain, how to assess and manage pain at home, especially when dementia patients, they cannot communicate or verbalize their own feeling and pain. So pain assessment, management of medication and side effects from medication, those are really hard for family caregivers. And also how to keep track of the use pain treatment or medication at home is a big challenge. And communication with provider is another issue. A lot of time, they feel provider is too busy to kind of explain how to do pain management for them. Or sometimes caregivers don't know how to report patient's pain condition or medication use at home with provider. And patient-centric issue is another challenges. A lot of time patients just don't want to verbalize, or sometimes it's inability to verbalize, sometimes it's don't want to talk about their pain because a lot of patients, they are afraid of treatment or use pain medication. And so this is one of my early work. Like I developed pain management manual, so like including pain management knowledge and also discussion questions that providers they can use to communicate with, to communicate and also collaborate with family caregivers in pain management. And I evaluate this manual with 25 interdisciplinary healthcare providers. Providers feel like these manuals can be a guidebook when they communicate or teach family caregivers how to manage pain for patients. But provider also suggests if I can convert my paper-based manual into a web-based platform and also engage family caregivers. They think that can maximize the usability of this manual. So this is lead to why I developing a web-based application for family caregiver. And I also conduct a review, try to evaluate existing intervention that supporting family caregivers in pain management, and also look at the existing smartphone apps to see what we already have out there. This is one review published in journal Pain and Symptom Management. I review, currently there are 25 interventions specifically for supporting family caregivers in pain management. And when I review those 25 interventions, I found most of them focus on cancer population, and only one design intervention to support caregivers or people with dementia. But this intervention, they require multiple in-person training sessions. So this is not really feasible for many busy family caregivers. And we all know pain management is really complicated, that including ongoing assessment, management, medication, side effects, communication. And when I look those interventions, most of them do not really comprehensive to cover many aspects of pain management. And also their training sessions, the length of their training session varied, and then most of them do not title report the fidelity of their intervention delivery. And most importantly, those interventions, they were not tested for implementation or translation. So this can explain why we do not have intervention in place in clinical settings to support family caregivers. And currently, my research team and I, we are evaluating existing smartphone apps. So we look at both Android system and iOS system. So we try to look at existing pen apps, and we found most of them are they are designed without engaging healthcare professionals or end users, patients or family caregivers. And they also do not show if the content is evidence-based. And also none of them specifically design their pen app for dementia populations or family caregivers. So since last year, we have actively engaged experts in dementia and also family caregivers to develop a web-based application for family caregivers or people with dementia. And our app called PACE app, Pain Control Enhancement Web-based Application. We choose a web-based application because web-based application allow family caregivers to access the app in different types of electronic devices. So it can be their smartphone, can be their tablet, or their computers. And so this is some features we include in my app, and those features we design is based on our preliminary study, how we identify what caregivers their challenges in providing pain management. We understand family caregivers, they experience a lot of challenges. So in a lot of challenges in providing pain management. So in my app, I have a screening function. So the screening function, including certain assessment questions, family caregivers can answer those questions, and those questions help us to identify what are the specific challenges family caregivers they face. So that could be medication management or pain assessment issue, or communication with healthcare providers. And then based on the result of the screening, we provide family caregivers auto-generated tailored strategies to address their concerns or challenges. We also provide template questions. So family caregivers, they can use those questions to communicate with their healthcare providers or ask questions. And we also have evidence-based resource library, so family caregivers can look up when they need. And we also including a digital pen diary. So family caregivers, they can document their pen diary at home and then share their pen diary with their providers during the clinical visits. So this is my conceptual framework. I hope the PACE app intervention, we provide family caregivers tailored strategies, and also pen diaries, those interventions can help family caregivers increase their self-efficacy in providing pen management, and also improve their communication with their care team. And then that can improve patients' pen and function, and also reduce family caregivers their burdens and anxiety. So just some screenshots of my app. This is the screening questions. We have 13 questions, and help family caregivers to assess and identify their challenges in providing pen management. And this is a tailored strategies. Once family caregivers complete the screening, they will get a one-page tailored strategies, and then they can review those tailored strategies to address their challenges and concerns. And this is our pen diaries. We provide family caregivers pen diary. They can document their pen management at home. And yeah, so we provide both verbal and nonverbal assessment tools for family caregivers, so they can document their pen management assessment at home. And currently, I'm planning to recruit family caregivers to test the usability and feasibilities of using this app. And our next step is we want to use the data we collect from our testing, and then upgrade our app to a machine learning integrative app, so we can provide real-time feedback based on caregivers, their pen diary entry. And ultimately, we also hope to connect the pen diary to the EHR system, so to enhance the collaboration and communication between family caregivers and their care team. And long-term goal is like we hope to disseminate this app through the national organizations, or partner with the community-based organization or clinicals, so we can implement and translate this app for more family caregivers. Yeah, so this is just what I have for this app research. And I know several of you also developing app for dementia populations. So I'm looking forward, like we can have more discussion and conversation on that. Thank you.
Thank you. So your app, has it been linked to
Not yet.
Epic? Oh, yeah.
Yeah. I want to talk to. I know you are expert in on that, so I hope to have talk to you on that. No, that will be the next. That will be the next step. Right now, we're still testing the usability and feasibility.
And say again what the output of the pain assessment is. So is it for clinicians, or do patients get a recommendation? I sort of missed that point.
Can you say one more time your question? You said the pen diary, or?
Yeah, with the pain diary, is it, what's the sort of, I see that you're saying here, the intent is to have it provide real-time feedback, but what does it actually do today?
Oh, it's a, right now we do not have this function, but in the future, I hope like after family caregiver enter their pen diary, so we can give them the pen management recommendation on pen management strategy. So for example, if they say, oh, they have some severe side effects from giving pen medication, not only provide some management strategy of how to manage the side effects, we also want to encourage them immediately talk to their healthcare providers.
Yeah. Okay.
Things like this. So this is why we want to connect to the EHR. If we don't want to kind of provide too much information or kind of information overload to the provider, but we want kind of like can alert provider if patients they have some big outcomes. Yeah.
Mhm.
Or providers they can have like longitudinal information on patients their pain management at home. Yeah.
And so in thinking about outcomes that you would track beyond the patient, like are you thinking like caregiver self-efficacy to kind of be able to manage pain?
Yeah. Right.
Oh, here you go. Okay.
Yeah, and also I'm also thinking about the adherence to their pain treatments. So yeah, I think adherence, I have been discussing this with Bar, like Dr. Barrenko, like in terms of the outcomes we measures, we are also thinking about maybe we will adherence to the prescribed pain treatments. Yeah, that can provide us more information on caregivers, their behavioral changes.
And just also thinking like how this could be repurposed, even expanded in terms of the idea that you're creating an app, especially as you start applying like machine learning and how we can actually just more broadly to the care management of a patient with dementia in general.
Yeah.
Outside of pain.
Right. Yeah. Other symptoms.
Giving decision support.
Yeah, that will be great. I think this is kind of a starting point. We look at pain right now, but other symptoms, other behavioral issues, I think that will be really hopeful for this population and their family caregivers. Yeah.
Questions?
Any questions were, yeah.
I think we were going to talk about even trying to see if we could support a pilot of the app for you at some point, maybe at a practice here.
Yeah.
In a very small way to.
Right. Yeah, I mean, two things to mention that we have going on here. I'm not quite sure either one fits, but just so you know, we have soon to be two randomized controlled trials in Northwestern medicine primary care practices for electronic health record based nudges to decrease polypharmacy. Is one of them, to sort of nudge clinicians and patients to discuss polypharmacy and sort of get them to make a commitment to discuss polypharmacy, which might tie into your first project. And then we've already done a pilot based on that, but then are going to be rolling out a larger randomized controlled trial. And then the second one that we're just going to be wrapping up an 18-month randomized controlled trial in June of nudges to decrease opioid prescriptions, but that's much more in primary care and not. You're talking about like a whole other level of, pain management for people with dementia. So insofar as we have like a lot of data about, what's changing with opioid prescribing, that's another potential area of connection.
Yeah. That's really meaningful research. Yeah, opioids. Yeah.
And I trust Lisanne you're talking about Allison's work, not ours.
That was
everybody's, but yeah, I was talking about Allison.
Yeah. Yes.
Yeah.
Great.
Yeah, and definitely, Michael, I will talk to you more about how to extend this research. I think they can go to a lot of different directions, different issues in people with dementia, or different issues, and also different way to integrate this app into the clinical workflow or clinical settings. Yeah, so definitely, have a lot to discuss and collaborate.
Yeah, no, I think this our Pepper Center, is geared towards patient-reported outcomes measurement and assessment, and that includes proxy and surrogate kind of assessments, and it also deals with technology-enabled design and also mixed methods research. So I feel like a lot across, you've done a really great job of showcasing, a very diverse portfolio of research that you're doing, and also you're not far.
Yeah.
So,
yeah.
And we kind of touted ourselves to be, that's a great recommendation, June, for the Judy Place connection. That would be a great idea, June. Thank you for that, Dr. McCoy. that anyway, so I really hope we can kind of extend
continue.
we're a Midwest pepper sample.
Right. And so speaking of that, when I talk about the multimorbidity research, I saying like I want to look at national sample data set, but I think maybe before that we can even look at this issue in Midwest that is large enough, and then also maybe we can compare rural and urban. This is just some ideas, rural and urban, their patterns of multimobilities. Just a lot of ways, directions we can think about.
Yeah, absolutely. Well, we're at time, but I don't know if there's any final questions, but I think we really thank you for joining us today. It's been really great. You touched on a lot of work that would work well for us too.
Yeah.
So anyway.
Thank you so
everybody.
much. For the invitation.
Allison, I'll talk to you soon.
Thank you.
Thank you.
Thank you. Bye.